we have one more speaker, which is Dr. Yuka Yumi. She's joining us online. She holds an MD from Kyoto Prefectural University of Medicine, a PhD from Osaka University, Japan, and an MPH from the London School of Hygiene and Tropical Medicine. She's a certified specialist in acute and critical care medicine. Since 2016, Dr. Yuka Yumi has been responsible for WHO Integrated Care for Older People approach, iCOPE, and developed iCOPE implementation tools. She's a secretariat of the WHO Clinical Consortium on Healthy Aging, contributing to the development of standards and guidance on the clinical aspects of healthy aging. Under this, she coordinates activities such as iCOPE implementation in countries and iCOPE training for health and care workers. Today, Dr. Yuka Yumi will discuss WHO's strategy on integrated care for older people approaches, or iCOPE, in humanitarian crises.
Thank you very much, Eva. Do you hear me well?
I'll try again. 1 second. Not yet. We're working on it.
Okay.
Yes, you're good.
Yes, hi, everyone. Do you hear me?
Yes.
Okay. So thank you so much for the opportunity. Sorry for not being in person, the presence, but I really enjoyed the discussion from the morning. So let me share my screen. Is it visible to everyone? Is it visible?
Yes.
Okay, thank you. So I'm really responsible for I'm not working in emergency at WHO. I'm responsible for the strengthening of primary care for older people by providing the integrated care for the people. As you heard, my background as physician before joining at WHO is emergency and critical care. So this topic is very close to my heart. So primary health care as a cornerstone of sustainable health systems for the achievement of UHC, universal health coverage, and sustainable development goals. UHC means that all people have access to the full range of quality of health services they need, when and where they need them, without financial hardships. It includes a full continuum of essential health services, from health promotion to prevention, treatment and rehabilitation, and palliative care. We also advocate for long-term care to be part of the UHC health package. And primary health care is a whole of society to health. As we discussed already, biological aging, the age number itself is only loosely associated with person age in years. Some 80 years old have physical and mental capacity similar to the many 40 years old, for example. Others experience declining physical and mental capacities at much younger ages. So there is no typical older person, meaning the healthcare or services needs to respond to the diverse needs of older people. In 2015, WHO defined healthy aging as the process of strengthening and maintaining the functional ability that enables well-being in older age. Functional ability includes different domains, such as meeting basic needs, learning, growing, and making decisions, being mobile, building and maintaining relationships, and contributing to the society, including their family. There are 3 key components important for healthy aging. Functional ability, that is combination of intrinsic capacity and environment. And intrinsic capacity is everything under our skin, so the composite of all the physical and mental capacities of an individual. Environment comprises all the factors in the outside world that forms the context of each person's life. that includes home, communities, and the broader society. Within these environments, there are a range of factors, including the built environment, such as housing, transportation, people and their relationships, attitudes and values. We discussed about it in terms of the cultural values, attitudes toward age and aging, health and social policies, and assistive technologies. In this slide, using the case example, 75-year-old woman with hypertension, I would like to highlight the importance of the continuum of integrated care following the trajectory of intrinsic capacity and functional ability. Red line shows intrinsic capacity on top, and then blue line represents functional ability. When we age, everyone in this room, including our intrinsic capacity, tends to decline, and the speed might be very different by ourselves. And older people might have diverse needs of health and social care. Enabling environment compensate the loss of intrinsic capacity so that in non-conflict settings, usually functional ability is higher than intrinsic capacity. On the bottom of the slide, there is a different services I described, including promotion and prevention of decline of intrinsic capacity, management of underlying health conditions, and care coordination and social support. So if older person has a pneumonia, of course, acute care needs to be provided. At the same time, to providing multimodal exercise, good nutritional advice with high protein and cognitive stimulation helps to prevent decline of intrinsic capacity. If older person has a hip fracture by fall, walking aid might be helpful for her to be independent as much as possible, besides acute care and rehabilitation. If the older person has a cognitive decline, that might require home modification to prevent further falls. If the older person has a significant loss of intrinsic capacity, home visit by health and care workers, assistive care for the daily living, and carer support might be needed. So I would like to highlight this is not only about one-stop diagnosing and treating and fixing it, but to follow the intrinsic capacity and the functional ability to identify the diverse needs of older people to provide personalized care. So what's going to happen if the humanitarian crisis happens? Infrastructure, supplies, and health workforce can be impaired or non-existent, creating very challenging environments. We discussed already about accessibility, and access to the healthcare is huge barrier for the healthcare for older people. So the most likely, even the older person physically, mentally, or in terms of the intrinsic capacity is still high level because the environment is not allowing older person to do what they have reason to value. So depending on the length of the crisis, their intrinsic capacity and functional ability might deteriorate faster than the non-conflict settings. So then, how can we ensure the continuum of integrated care in the humanitarian crisis? I talk about the primary health care. So role of primary care in humanitarian crisis. Primary care is the first contact of health services that is people-centered and continuous and comprehensive and coordinated. Primary care has an essential role to play in preventing, preparing for, and responding to, and recovering from any humanitarian crisis. As primary care has pre-existing links with communities, we really touched on the community, importance of the community, has the capacity and networks to understand the environmental, social, and cultural elements that affect health. It can deliver context-appropriate care as well as effective risk communication, and continuing work with the communities through the emergency into recovery. Integrated care for the people approach, iCOPE, is the WHO's approach to provide a continuum of integrated care that helps to reorient health and social services towards more person-centered and coordinated care. iCOPE supports optimizing intrinsic capacity and functional ability for older people so that older people can continue do things they value. Implementing iCOPE as a part of universal health coverage is one of the action areas of UN Decade of Health Aging 2021 to 2030, and it closely related to the another three action areas, which is combating ageism, providing age-friendly environment, and providing long-term care for those who need it. We have tools to implement iCOPE. That is, iCOPE Handbook is a technical resource to support health and care workers to put evidence-based recommendations into practice in primary care, including community. The handbook describes practical care pathways to be adapted, which is very important, to be adapted in a local context, including humanitarian crisis, to detect the decline in intrinsic capacity and develop a personalized care plan. Handbook explains how to prevent and manage the decline with different domains of intrinsic capacity, namely cognitive decline, loss of mobility, malnutrition, vision impairment, hearing loss, depressive symptoms, as well as key factors in older people's health, social care and support, carer support, and urinary incontinence. This is actually, as you can see, second version, the learning from the field to make that as usable as possible for the field workers in primary care and community. So what does evidence-based interventions to manage decline in intrinsic capacity? That include many other behavioral interventions that can be provided in the community, encourage multimodal exercise, strength, balance, flexibility, and aerobic training, dietary advice and oral supplemental nutrition to those who are undernourished. The previous presenter talked about the nutrition issue for older people. This is critical, related to also the mobility. Vision impairment, screening for the vision impairment and offer comprehensive eye care, including cataract and different age-related vision impairment, screening hearing and offer hearing aids as needed, and cognitive stimulation and psychological intervention. The other interventions to manage geriatric syndromes and support carers, including prompt voiding, pelvic floor muscle training, just the advice how to do the toileting is also important, and preventing falls, including medication review, multimodal exercise, home hazards assessment, and adaptations, and supporting carers. Many countries actually rely on the family informal carers, offer psychological intervention and training and support, including respite care. So iCOPE care pathway explain how to do this in a stepwise way, from the basic assessment and the intervention to the in-depth assessment, develop a personalized care plan, implement and monitor, and then reassess according to the care plan, as well as after acute event or illness, including humanitarian crisis, and when social role or living situation changes. As you can see in the first on top, there is a green highlighted part. This is really for the regardless of the loss of intrinsic capacity, how can we provide the health and life advice and promote self-care, including vaccination? How can we identify the need for social support and provide the support? And then this is really important, the basic assessment to do that regularly. And then if the person fails the basic assessment, the community-based healthcare for intrinsic capacity loss can be provided. And then in ideal world, referral to primary care. But we witnessed, even not conflict settings, there is a bit of a gap between the community and primary care. Either older person decide not to go to the primary care because of the accessibility, availability, affordability of the primary care, as well as sometimes the intrinsic capacity loss, they don't consider, oh, it's not too severe, why do I need to go to the healthcare facility? Of course, that requires a bit of education and health literacy. And then many times there is a long waiting time to the primary care or specialized care. We can still provide community-based healthcare to address different needs of older people. And then if the older person can access to the primary care, the assessment needs to be comprehensive and person-centered. That include loss in intrinsic capacity, further assessment of losses in intrinsic capacity, underlying disease and risk factors, as well as social and physical environment. And then based on these findings, to discuss the findings, to identify the priorities, and then to develop the personalized care plan. There are very simple tools available. We call it the basics assessment for loss of intrinsic capacity. Based on the field experience, it takes around 10 minutes to ask question, or that's a simple test, including chair rise test. Of course, you need a chair, but other than that, it's mostly any healthcare worker or a community stakeholder with training can do this basic assessment for the loss of intrinsic capacity, and then as well as key factors impacting older people's health. So since we talk about the community, I really want to highlight that there are community level interventions that are feasible for community stakeholders with some training, including first step basic assessment for loss of intrinsic capacity, identification for need for social support and support for carers, health promotion and prevention, promote healthy lifestyle, and identification and management of the cardiovascular risk factors. You can start just measuring blood pressure, and community-based healthcare to address loss of intrinsic capacity. And the other step 2 to 4, awareness raising, transport to the healthcare facilities, delivery of medication, mapping of available resources in the community, organizing social events and activities, peer support groups, and the creation of age-friendly environment. Many countries actually demonstrate examples of the older people themselves. We just heard from the different presenters. The older persons association actually take a role to promote this iCOPE approach. So adaptation of iCOPE in humanitarian crisis. Every health system and the service delivery are different before the crisis or during a humanitarian crisis. And the nature and severity of humanitarian crisis varies. And humanitarian action should be approached in integration with local health and social care services and reorient and improve the capacity. We talked about scarce resources. That is the reality. So how can we utilize existing cadres, including community stakeholders, to support older people? And health workers in primary care and community stakeholders play an important role to provide the continuum care. This is one of the photos that I took. I myself experienced a huge earthquake in Japan, March 2011. As you can see, I was queuing to get the water from the self-defense force in Japan. Imagine for the older people, they need to queue. This was March in very cold weather to queue to get water. And then I had the opportunity to visit the Ukraine in 2022 as well. So I'd like to ask the participants here, how can you adapt this iCOPE approach in your humanitarian context for the everyday practice? Thank you very much.